My name is Dr. Roger White. I'm in the Department of Anesthesiology and the Division of Cardiovascular Diseases in Department of Internal Medicine and the Department of Emergency Medicine, Division of Pre-Hospital Care at the Mayo Clinic in Rochester, Minnesota. The case we're discussing will be online soon and will be published in the June issue of Mayo Clinic Proceedings. This is a remarkable case because this patient made a complete neurologic recovery following a very prolonged out-of-hospital cardiac arrest with resuscitation that was guided by continuous capnography, the measurement of end-tidal carbon dioxide tensions throughout the event. We were confronted with a 54-year-old man who experienced an out-of-hospital arrest that was witnessed by a bystander. He was outside a grocery store on a very cold winter night in a small community in rural Minnesota. He received immediate CPR by the bystander and also by a trained first responder who happened to be nearby. Thereafter, a group of trained first responders with an automated external defibrillator arrived about 5 minutes after he collapsed. And over the course of the next 24 minutes, a vigorous resuscitation was executed by these first responders, during which they delivered a total of 6 defibrillation shocks for ventricular fibrillation that recurred or persisted after each shock. Fortunately, the presenting rhythm was ventricular fibrillation, which gave us a survival edge. After that, in about 34 minutes from the time of receipt of the emergency call, a flight crew from Mayo 1 helicopter arrived at the scene and carried out the resuscitation with advanced life support techniques and interventions. It was this experience that ultimately turned this event around into a survival, despite the fact that it occurred over 96 minutes of total pulselessness. At no time were the rescuers able to feel a pulse over this entire period of time. The flight crew then started an intravenous infusion, inserted an endotracheal tube, and began immediate measurement of the end-tidal carbon dioxide tension. This is a measurement that tells us how much blood is flowing through the lungs and therefore to other vital organs. It's a measurement of pulmonary blood flow and therefore cardiac output. This measurement was a lifesaver for us because it guided everything that we did thereafter. The flight crew, after having started the IV, administered antiarrhythmic drugs, amiodarone and lidocaine, and also epinephrine. Thereafter, they also delivered a series of 6 defibrillation shocks with their advanced life support defibrillator. Each shock either resulted in persistence of the VF or termination, but only transiently. When termination did occur, a pulse could never be palpated. Remarkably, however, throughout this effort, the end-tidal carbon dioxide tension remained in the range of 33 to 35 millimeters of mercury. And the only time it fell below that was when they had to stop to deliver a defibrillation shock, so that we were able to maintain remarkably high pulmonary blood flow with chest compressions and ventilation. And this resulted because we had a group of trained rescuers who knew how to deliver effective cardiopulmonary resuscitation. And also, because there were so many of them who contributed to this effort, they rotated the responsibility of provision of chest compressions throughout the rescue, so that we always had a group of fresh rescuers to begin a new bout of chest compressions. Compressing the chest in a cardiac arrest victim is a very fatiguing process, and it requires a fresh rescuer to rotate, and that's what we had available to us, people who were able to help us to continue this effective chest compression effort. So we got to the end of the line. We had already delivered 5 more defibrillation shocks, which now made a total of 11 shocks, including the 6 delivered by the first responders. And we still had not restored a functional cardiac rhythm. So we gave another large dose of an antiarrhythmic drug, amiodarone. We gave 300 milligrams, thus making a total of 600. And after that, we did CPR for about 2 minutes and delivered the 6th advanced life support shock. After that 6th shock, which is now shock number 12 total, a pulse gradually returned. And we calculated the total time during which this patient remained without a pulse at a minimum of 96 minutes. It may have been a little bit longer, but certainly 96 minutes was a minimum time during which he maintained pulselessness. At the end of that 6th shock, the carbon dioxide tension was 37 millimeters of mercury, an organized rhythm was present, and after several more minutes, a peripheral pulse was palpable. So we had achieved our endpoint. We had, in a sense, defeated relentless ventricular fibrillation. Guided by capnography, we persisted in the performance of cardiopulmonary resuscitation throughout this prolonged period of cardiac arrest, and we were able to obtain and maintain a sustained spontaneous circulation. With that endpoint, we placed him in the helicopter and brought him to St. Mary's Hospital in Rochester, Minnesota. He was taken immediately to the cardiac catheterization laboratory after a few minutes of stabilization in the emergency department, which he needed. And at the time of emergent coronary angiography, he was found to have a total occlusion of the left anterior descending coronary artery with a fresh thrombus. He underwent an aspiration thrombectomy, a PTCA and stent placement, left the cardiac catheterization laboratory, went to the coronary care unit. He had a stormy course with a pulmonary edema, acute pulmonary edema, cardiogenic shock, and acute renal failure. Remarkably, however, he recovered from all of these adverse events. And on 10 days following his admission, he went home neurologically intact. And subsequently, he underwent an uneventful coronary artery bypass operation to correct the remaining underlying coronary artery disease. He recovered from that also uneventfully and is home continuing to make a recovery. Eventually, he will have his hip replaced, which was his first medical indication for an intervention. He had injured his hip as a motorcyclist, and the plan was to replace the hip, but the cardiac arrest supervened, and that became the priority. So this patient made a remarkably complete recovery from a remarkably long cardiac arrest with continued pulselessness, but the effort was successful because it was guided by capnography, which kept telling us that cardiac output was good, that we should be preserving his brain and his heart if we persisted, and if we could finally find a way to terminate the relentless ventricular fibrillation, we should have a survivor in our hands. And that's how it worked out.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.